Well, one is for Brad, and that's from, do you routinely give patients thromboprophylaxis post-surgery that are positive for COVID? Brad, that question is for you.
Just hold on.
Okay. Do you routinely give patients thromboprophylaxis post-surgery or positive for COVID?
I've got it. Okay. Yes, I think COVID does increase the risk of thrombosis, and but truth be told, I don't do any surgery on anyone who's got COVID. I do elective surgery only. That anyone who does have COVID or is at risk, I do, and I think should be treated. Just as an aside,
I mean, I'm going to be addressing it in my talk, so we'll. Sorry, you were saying, Brad?
So just as an aside, in the last 2 months of surgery post-COVID, I've had my highest DVT rate post-surgery in young, healthy patients that I've had in the last 10 years.
Right.
Whether it's COVID-related or not, or something else is going on, I'm not sure, but it's just very interesting.
I think it probably is COVID-related, but I'll be speaking to that a bit later. We've got a patient here, and this question was for Elise. Patient with AF on warfarin. Maybe it's also for Sylvia. I'm not quite sure which of the two it was for, but both of them can address it. Patient with atrial fibrillation on warfarin for a knee scope. Warfarin stopped 3 days prior to surgery, and surgery day of surgery. How do you reinstitute warfarin therapy post-operatively? So someone that you would, in other words, someone with known AF that you want to reinstitute warfarin, what is your program?
Elise, would you like to take that question?
Thank you, Sylvia. So in that instance, it's not necessary to overlap with heparin. You would measure the INR post-op, and once you've achieved hemostasis, you can reinstitute warfarin 6 to 12 hours post-op. If you've achieved hemostasis, you can safely reinitiate the warfarin. If the indication for the warfarin initially was AF, in the clinical trials, warfarin and heparin were not overlapped for AF patients. So you would restart your warfarin therapy 6 to 12 hours post-op if the patient isn't bleeding, and you would monitor the INR within 3 days. And you would start at the usual dose.
Mm-hmm. Thank you.
Okay. There was a question. About the clotting time, and it's an old test that was done in the past from Jenny Hall, where they took blood, put it in a test tube, and then measured the time taken to clotting. It was an old test that was done prior to the use of INR that was available, and then that was what Elise answered there. So that was one question. Another question was point of care testing. Elise, you want to maybe speak to that?
Yes, so there are several point of care tests that are available in South Africa. These are small handheld monitors which are easy to use. The limitation, as I mentioned, with them is the medical aid coverage. And I have replied to you and to the person who asked the question, and I will email you the various suppliers. And they're quite reasonable as far as cost goes.
And then there was another question about mitral valve replacement patients who are over warfarinized, and would you give them vitamin K?
So yes, vitamin K can be used, but with caution in patients with mechanical valves. It should never be used intravenously. And when administered orally, you have to be aware of the risk of overcorrection, and therefore these patients need to be monitored very cautiously. So therefore, we would administer a smaller dose of 1 milligram of vitamin K. This is generally to the patient who presents with an INR of greater than 10, and we wouldn't use it in the region of 4.5 to 10. These patients would need to be referred to their cardiologists and need close monitoring to avoid overcorrection.
All right, I think that's answered all the questions. There are no other questions that I can see that have come up, but you're welcome at any stage to put them on the chat or in the Q&A, whatever you prefer. But I'd rather do that in the Q&A, and we will address them. We're now going to move on